Important session on how do we find our way through the medico-legal maze. In the recent years, the patients' expectations have gone on various accounts. One is they have a much better awareness, either which they find on their own from the internet and the web. There are a lot of resources, but there are also a lot of information. We as providers, provide the patients through various public media. And again, the increasing cost of the healthcare is also something that has driven the patient's expectations. And again, many of these things are also a lot of patients. What we used to say that nothing can be done, now the patients make several visits to the hospitals. There are patients who have even received 100+ injections, intravitreal injections in their eye. And again, the ophthalmology is also becoming complex like any other field. Earlier, one disease used to have one kind of a treatment. Today, we have multiple treatment options. Even that multiple treatment options, there are multiple ways you can provide the care. So patients are also confused, and probably the physicians are also equally confused. All this discussions we hear in the meeting all revolves around that. So, and there are many things which we can do to avoid this, and we have I am joined by my co-chair, Dr. Madhavan, who is a senior experienced ophthalmologist from Erode, and also Dr. Murali Ariga, who will be moderating the whole session. We are also joined by several panelists, Dr. R. Ramakrishnan, who is the outgoing president, Dr. Nirmal Frederick, who is the incoming president, and we have ophthalmologist Dr. Senthil Kumar. We are also joined by Dr. T.N. Ravishankar, Dr. Senthil Kumar, Mr. Rajendra. They are from the Indian Medical Association, who are well versed with all the medical legal problems. And we also have a legal luminary, Mr. Rajendran, and we have a speaker, Dr. Ilankumaran is joining us from Bangalore, and Dr. Subhashini and Dr. Satyan also will be giving the talks. I just hand over to Dr. Madhavan and Dr. Murali to take over the session. Yeah.
Thank you, sir. In the day in which we are having so many clinical and other related talks, this is an off-the-cuff, but at the same time, a very important topic for us all in our day-to-day practice. Medico-legal activities have become a part and parcel of our clinical practice. Whether we like it or not, we have to be well-versed, we have to be proactive, and expect trouble, and to see that the trouble doesn't occur is the challenge that we face nowadays. I would request Dr. Murali Ariga to continue and do the need. Thank you, sir.
Thank you all. I think we have a wonderful panel today, and I think we have a lot of aspects to discuss. I think we will not keep you waiting with the talks, and we'll get started with our first speaker. I request Dr. Ilankumaran to speak. Thank you, Ilankumaran, for coming all the way from Bangalore and enlightening us on the various aspects of documentation and medical records. And we'll have the talks first, and then we'll probably go in for the panel discussion in detail. We have enough time for the panel discussion.
Thank you, sir. At the outset, I would like to thank TNOA, the office bearers, the scientific committee, and the organizers for giving me this opportunity. This is my first TNOA conference, and I am really proud to present in the presence of people whom I learned the nitty-gritties of ophthalmic as well as clinical as well as non-clinical ophthalmic management of a health setup. Documentation and communication, these two things are words we rarely read about in medical school. However, when you look at practice, forget about practice, even in the teaching institute nowadays, it's highly emphasized on. Today we'll be talking about documentation. These records are not only required for us to memorize what had happened to this patient, recall what has happened to the patient previously, also to communicate with a fellow member if we are not there, of course, for health insurance and statistic purposes. But most importantly, with the present rules, I had not seen a patient ask for his old record 15 years back, but of late, almost every person asks for his record, and we are liable to provide it within that frame of time. And most importantly, to defend us in case of a mishap, just to show that we have did everything properly. We would have did everything properly, If we have only spoken and not documented, this is what happens. Spoken words fly away, written words stay. We can be held liable by the patient, by the court for anything. So who should, when and what should be documented is a question. Who? It has to be documented by everyone who is involved in the care of the patient. That said and done, the captain of the ship, most of us, individual practitioners or small hospital owners, the owner of the hospital or the doctor is responsible for that document. Even if someone else has written, it is his duty to check and make necessary correction. How to make the corrections? We'll come to that. When should we document? As soon as the consultation or the surgery or a procedure is over. However, if the person were to be in an operating theatre or he is treating an emergency, usually doesn't happen in eye hospitals, but if it happens, then we are allowed to either dictate. Dictaphone is not available in India. At least make a short note, make the assistant take a short note and later on fill in this report. But while filling in the report, it should be clearly documented that the incident happened at X time and it is being documented at Y time for whatever reasons. And what should we document? Everything what you do to the documentation. How should this document be? Remember this C. It should be clear, clarity. Should be in a chronological order so someone can see the story, so see the history clearly when he goes through the records. Consent, very important. It should be concise, but it should be complete also. History in client's word. When we write the prescription, the medicines, the complete formulation has to be mentioned, and the last two things, it has to be confidential. One more thing what I added was the compliance. In case the patient has missed the drug or taken the steroid or some other drug excessively, better to mention it so that the outcome is not. Now how do you, the last C, how do you correct the record? This is something which I wrote down just to show it here. In the first example, I have struck it off and then written. Can't even make out what I have struck it off. The ideal way is to strike off what is there and write next to it. If you strike off like this, it means you are tampering the record. Please don't, or overwrite it. If you have to change a record, it should be mentioned clearly. In digital record, what we do is errata. We mention the previous notes and corrected notes. That's what we do in the digital records. One important part of documentation is to get a consent from the patient. There are a lot of controversies, but what we follow is what I'm going to talk about. Now, I didn't know this till we started the NABH. I used to think till 18 years we need the consent of the patients to examine. It's not so. Till 12, we need the patient's parents or legal guardian to give us the consent. But 12 to 18, we can examine this patient with the consent of that patient itself. However, if any procedure is taken, then we need the legal guardian's consent. What are the consents to be taken? There is a question. Normally we used to take a general consent, something like what I have added in the top part. But then, in between, there was something that said implied consent. If a patient were to come to your clinic, that means he is asking for your treatment, so you don't need a consent. It's wrong, because the patient has come for treatment from me, from the doctor. However, in almost all our eye hospitals, there are a lot of others who are involved with this patient care, so a consent in writing is required. The other thing what we used to do, this is my own consent long back that was taken. We had some general consent like this, each and every procedure was done. What is now better format, advised format, is to have individual consent, mentioning what, we'll come to that later, separately for these patients, a comprehensive one for each and every procedure, or a group of procedures should be there. Inpatient, as regards inpatient, there's a very good book that has been released by All India Ophthalmic Society, and I think all of us know that it has to be in 2 languages, consents or whatever paper we keep, local language and English or Hindi, whatever. Now we can take reference from this All India Ophthalmic Society and then create our own consents. I was very happy with this consent, 4-page consent, which was half a page initially, became a 4-page consent for my cataract surgery. Almost everything mentioned, type of surgery, alternatives, purpose of the surgery, alternatives of the thing, whether the patient has agreed to it, what are the type of lens involved, what has he opted for. He has the time to ask us questions, and this consent was given to the patient well in advance, 2 to 3 days in advance, then signed on that day. That is also documented. Later on, what I realized was this. We used to think topical anesthesia does not need a consent. Of late, I just started hearing, this is still hearsay, even topical anesthesia take a consent. In case you convert or in case something happens, better take a separate consent. Imaging, of course, all of us knew we need to have a separate consent. Now, what do we document in the OPD? SOAP, subjective, objective assessment and plan of action. What are all this? This record looks good. However, what is missing according to the MCI norm is these two. I don't think any of us are using. I found out, now we are trying to add this to the record. This is what is missing. The occupation and the address, though we have taken this and recorded it somewhere else. Now, what do we do in documentation in the OPD? History, as told by the patient. So it's subjective. Findings should be objective. So whether we document or someone else documents, it should be the same. Assessment, the diagnosis and plan of action. I couldn't show it here, but what's more important is, should not write the brand names. Once this printout is given, actually, the composition comes out. And then, instead of writing review after 3 days, 4 days or 5 days, mention the date. So that he takes an appointment and comes back, and mention that also. What are the other documents that needs to be kept? It's a very extensive subject. Covering it in 10 minutes is like, though I have not studied Tamil, it's like that Tirukural, whatever was said, Anuvai Pulandu Kadale Pothi, something like that. So it's like that, but these are the important things for a patient. This is an inpatient document for one of my patients. These are the important things what I've marked there are very, very important. A consent form, inpatient admission form, inpatient initial assessment form, and these nursing notes. Nursing notes before the start of surgery and at the point of discharge of the patient. In case something happens to this patient, we can prove that he was all right in our care. And of course, the surgical safety checklist, so that we have checked everything that we have did it perfectly. Again, documentation extends, but I have marked something in blue. I had this incident just a couple of months back, not in my OT, it was in the OPD. Someone who was just sitting there collapsed. Somehow we could revive and take him out, and that is the time I learned. Though I have revived, I have sent him to the other hospital, made sure he has reached the hospital, code blue format, that form has to be filled. Lot more, we can keep on talking about it. The two things that are missing here, biomedical waste, we had a register, but what was missing in that register was every time what was handed over to the person, MRD audit checklist. The list keeps going on. I've come to the last part of it. Of course, add to this the quality indicators. Ours is an entry level, so it is less. However, these are the checklists that we are planning to do. So, extensive coverage. Now, the second question, which is better? Manual maintenance is easy to write. We feel it's easy to write, but it is not complete. Maybe it's easy to write, it is not easy to retrieve. Also, in case of an eventuality later, say 3 years, 4 years down the line, in case everything has to be produced, it's not concise enough to be sent to the patient. These are the 3 major advantages of a digital record over a physical record. However, certain things cannot be present, cannot be kept in the digital form. Example for that is a consent. So, some of the documents in my place are kept as a physical document, most of it in the digital document. Even the physical documents are signed. How long should we keep it? I'm at the last part of the slide, sir. How long should we keep it? Various laws that talk about this. The MCA initially was silent on the OPD thing, meaning we need not have to keep the thing. But there's a draft that's coming up, 2022 draft, which says 3 years. So, in a nutshell, what should I say? OPD, minimum 3 years. IPD, from 10 years, it has been reduced to 3 years. MLC, lifetime. Please remember this. Keep these records accordingly. There are 2 things I didn't mention. In the hospital thing, certain things what we learned. Generator, you have to keep a report for that. Oxygen, you have to keep a report for that and keep a backup report for that. This is what we learned when we started medicine, primum non nocere. If Hippocrates was there, I think he would have had a nulla documentum, nulla defensio. Thank you for the opportunity provided, TNOA. Thank you, sirs. And one last slide. This year, Karnataka Ophthalmic Society is in Bangalore. I invite you all for that. Thank you.
Thank you, Alan Kumar, and thank you, Andrew. I think very nice, very clearly put forward, and I think we have covered most of what has to be done by all of us in our practice. We'll discuss further in our panel discussion. Thank you, Alan.